My name is Kinnan Ross McKinnon, and I'm an assistant professor in the School of Social Work at York University, and I study gender-affirming care policy and practice. In this presentation, I'm going to discuss some of the socio-political contexts upon which transition-related care is practiced, and I'll also engage critically with the notion of transition regret. I'll start off by introducing two quotes. This was a letter written in 1962 from a physician to the Erickson Educational Foundation, which was one of the first trans health research institutes in the United States. And mayhem here refers to wartime legislation, which rendered it a felony to willingly amputate a limb to avoid military service. And that legislation stayed on the books for a few decades. Later in 2017, clinicians at the Advancing Excellence for Transgender Health Conference were instructed that a good decision at the time can still be later regretted. Clinicians' fears of regret have been persistently salient across decades of practice. And why is that? For clinicians and surgeons specifically, learning to be comfortable with future unknown outcomes of medical decision-making is part of the job. And surgeons in particular have to tolerate, at least to some degree, uncertainty with procedural and technical choices, patient recovery and aftercare, and patient expectations. There's complex internal and external dimensions that all come together to shape patient outcomes, impacting patient satisfaction or potentially regret. But I want to stress here is that the sociopolitical history of transition-related medicine, in particular, has been predicated upon mitigating perceived risks of transition regret, which has unfortunately had long-lasting damages on the alliances between trans patients and their clinicians. And today we see regret being weaponized to place legal restrictions around hormonal and surgical care, particularly for young trans people. So in the UK, Sweden, and the United States, we've seen sweeping legal decisions which place new limits on young trans people's access to either hormone blockers, hormone replacement therapies, or surgeries in some cases. In the past year, the UK High Court ruled that young people under 16 are unlikely to have capacity to consent for hormone suppression treatments. In the US, several states have either introduced or passed legislation that make it a felony for clinicians to provide hormonal therapies to trans people under the age of 18 or 21, depending on the state. So we're seeing rapid legal restrictions unfold, which risk trans people's health and well-being, and also limit clinicians' professional jurisdiction. Here's a quick snapshot of the history of transition-related care for adult and adolescent patient populations, because the practices are a bit distinct. They have unique histories as well. So the practice of administering hormones and surgeries in the treatment of gender dysphoria in the adult patient population began in about the 1950s, 1960s in the United States, although it was also practiced in some European countries as well. And it was largely predicated on very strict and subjective assessments that were all about discriminating against who was the ideal candidate and a worthy candidate against those who were less serious about pursuing transition. So this ideal candidate was often white, employed, a good citizen, unmarried, single, or if they were married or had children, for example, they were required to abandon their families completely in order to access hormones and surgeries, or they were rendered not serious. And that was largely in response to the political and legislative context at the time. So it helped physicians working in this area to create more professional credibility at a time when trans medicine was largely viewed as quackery by the overall medical profession. And these strict assessments ended up culminating into the development of the WPATH standards of care, which were first published in 1979. And these were the first psychosocial eligibility assessments to determine access to hormones and surgeries for trans people. And then around the 1990s, we began seeing practices of hormonal suppression in adolescent patient populations. And the first study reporting on these practices of puberty suppression came out of the Netherlands, and then also some other European countries followed suit, and largely with the patient population of ages 12 to 16. And this was introduced in order to give patients as well as their families some time to explore gender identity and to determine whether this is the right course of treatment, medical transition. The WPATH standards do have a chapter providing clinical guidance on hormonal blockers. Within the WPATH standards, the Endocrine Society also has guidelines and endorses this medical treatment in this age group. Now, important to note is that no surgeries, particularly genital or any surgeries that impact fertility, are indicated for patients under the age of 18. Although on a case-by-case basis, chest or breast surgery may be recommended for those ages 16 and above if they have parental consent. So all of these comprehensive eligibility assessments are really about, they reflect medical ethics and avoiding doing harm, but it also really boils down to preventing, quote unquote, regret. So let's talk about surgical regret. This was a systematic review conducted in 2020, published in 2020, and included a meta-analysis. It included 27 studies that were conducted internationally. And these studies pooled a sample of 7,928 trans patients who had received any type of transition-related surgery. And what they found was that the prevalence of regret with this pooled sample was under 1% amongst transmasculine and transfeminine. They also conducted separate analyses for transmasculine and transfeminine procedures, also revealing under 1% regret rate. And of that pooled sample, 77 patients indicated regret either sometimes or always. And one of the major limitations of this literature is that there isn't a validated or standardized measurement for understanding regret, or even how that's taken up by trans patients themselves. So what about surgical regret in other domains? This is a systematic review that was published in 2017, and it looked at regret in surgical decision-making from patient and physician perspectives. It included 73 patient studies, 6 physician, and of these studies, 57.5% focused on cancer surgeries, and largely breast and prostate cancers. This review revealed patient regret prevalence of about 14% across these studies. So about 1 in 7 patient expressed regret. And the researchers conclude that regret is relatively uncommon, which I find to be quite fascinating in the context of transition-related surgery, where the regret rate is estimated to be more around 1% or less for surgeries. So in the decades of standardizing diagnostic criteria and a model of care, we were left with 2 things: a fairly narrow, unidirectional gender transition pathway, which requires trans patients to be absolutely certain about where they're headed medically and in their lives. And 2, the complete absence of clinical guidance for when patients need to take their transition in a different direction. Essentially, there's no clinical guidance or information for providers or for patients for what to do when there is regret, or if transitioning was not the right course of treatment. Sometimes people need to try medical transition in order to decide if that's the right fit for them. So this is a very early nascent area of research with terminology very much in flux. But generally, detransition refers to discontinuing or reversing the transition process. And sometimes people retain a trans identity, but sometimes it shifts to something else, maybe non-binary, sometimes cisgender, or something in between. Retransitioning is a broader term, and it may include stopping and restarting medical transition or a shift from a binary trans identity to a non-binary trans identity. But it's important to recognize that people who fall into these groups have unique experiences, and regret is not always synonymous with detransition. Some people detransition and they don't regret their transition. And some people regret transitioning and they don't detransition. So why do some people regret their transition and why do some detransition? Well, it's complicated, and so far there are very few published studies in this area. So these are some of the reasons provided for people's detransition pathways. This is what the literature has captured so far. And there's only a few studies that I can even think of off the top of my head that study these factors. But what you'll note is that these factors are not something that could be identified through comprehensive eligibility assessments, and thus regret and detransitioning may be unpredictable. Though increasingly, mass media amplifies a very narrow narrative of transition regret and of detransitioning. That more and more people are detransitioning, and we need to be worried about this. That it's life ending, and that clinicians are to blame. But interestingly, this media analysis found that between 2015 and 2018, there were more than 50 articles published on detransitioning in the UK and the US. But around the same time, a survey of 46 surgeons in the US and Europe who had surgically treated over 22,000 trans patients identified 59 cases of detransition, so about 0.26% for surgical detransition. And these surgeons, a majority, were recalling a practice timeline of over 10 years. So something is amiss here from what's presented in the media. But on social media, detransitioners are sharing stories that counter this idea that detransitioning is always regretful or life-ending. So bear with me for a minute and I'll show you a TikTok here.
So I'm really happy that this question was asked. So thank you for asking that because it really did weigh on my mind heavily. And I think that because I was so supported and I was really happy in my transition to male, that I felt that people would use my documentary as a way to invalidate my experience. After realizing that my happiness is what comes first and people are going to say whatever they want to say, I ultimately decided that I was going to detransition. And that means something different for everyone. Like my documentary, I am going to continue to document, probably not in the same platform, but all of my changes and what's going on in my mind and what led me to this decision. Ultimately, I realized that it doesn't matter what anyone thinks of me, how they perceive me. It matters how I perceive myself and how I feel comfortable in this world. I still want you guys to share my documentary, watch it. If it still resonates with you, that's okay. That was a very real experience for me.
TikTok. So I have a few take-home points. First, regret is unpredictable. And I'd like to take that a step further. I think trying to prevent regret or detransitioning is fraught and loaded with biases and impacted by narrow media representations. And similarly, detransitioning is dynamic and experiences vary, just like gender transitions. And lastly, regret is rare. Surgical detransition is even rarer, in less than 1%, based on the published studies that have been conducted over the past few decades. Though when surgical regret or detransition happens, some patients do report surgical pain as one factor. So there is a need to continue to innovate surgical techniques, which could improve patient satisfaction and quality of life outcomes. And on a related note, we do need more rigorous and longitudinal surgical outcomes data to better understand how trans and detrans people are doing long term. And these data are also necessary for surgical innovation. Still, even though detransitioning is rare, we also need to develop supports and resources for people who are detransitioning. That needs to be to also establish patient-centered care and patient determination and autonomy in care. And we also need better clinical guidance when we're working with this patient population, and that may be even delivered under a gender-affirming care model. Thank you so much for listening. And if you have any questions, comments, or feedback, please feel free to reach out at my email, kinnonmk@yorku.ca. I look forward to continuing this conversation. Thank you.